Hi there, my name is Elisa Doherty. I'm an occupational therapist and certified lactation counselor, and I'm going to be discussing with you all today My Baby, My Feeding Plan, meeting long-term infant feeding goals in the outpatient setting. My disclosure statement today, I have received payment from Dr. Brown's Medical as a presenter in this webinar. I personally developed this slide deck strictly for educational purposes and audiences. Images and photographs used in this presentation are from publicly accessed sources. It is without bias and is evidence-based. I will make no recommendation for any off-label use of pharmaceuticals, nutritional supplements, or devices. The objectives today, after attending this webinar, the nurse or therapist or any other medical personnel attending will be to be able to describe two clinical characteristics infant experiencing feeding difficulties in the NICU. We'll be able to list at least site intervention to increase an infant's feeding success with either bottle or breast. We're also going to be able to outline two or more parent education topics related to infant cues and state control as they relate to infant feeding success or difficulty. So kind of to start us off, these are the thoughts. My baby is home, but what about my feeding plan? How your infant feeds at the time of discharge is very different than often the long-term feeding goal. And we're going to be talking more today about how feeding therapists can help. Being a mother is about learning strengths you didn't know you had and dealing with the fears you never knew existed. Little quote by Linda Wooten. The idea is the infant feeding is one of the first developmental goals that mothers think of when their baby is born. And as care providers to infants, we have an imperative role to play in the infant's feeding development. We can promote the most special bonds between mother and baby and foster the growing confidence that a new mother can provide nourishment to her child. So when we think about having children, we think about when we're going to have that baby, what the baby is going to be, how that birth is going to go, and right after that, how we want to feed our baby. And as therapists and nurses and any other care provider, we oftentimes rise to the occasion when that transition of what the perfect plan looks like is interrupted. Our job is to help get that little one back on track to be able to achieve milestones. Utilize the tools of positive reinforcement with evidence-based practice. So when we think about learning any type of task, the foundations of learning are the same. We combine these educational approaches with developmentally appropriate goals, and that is the key to success in achieving infant feeding. So how are we supposed to learn how to eat without having those positive skills being reinforced? The baby's supposed to know how to eat. Of course, they have those intuitive processes that are in place when it comes to reading reflex and suck reflex. But what happens when that baby is born too early or that feeding is interrupted because of medical complications? How do we get them back on track? So the role of the infant feeding therapist is to evaluate the infant's oral, motor, and musculature functions. We look at state control. We talk about neurobehavioral coping abilities. How much are they eating? What's their PO intake and how much do they need to eat? What's the oral sensory motor function, the tone, and how are we going to assist them in the progression of these oral feedings through supportive feeding techniques? We can't just be the feeders of these babies. So how are we going to educate parents in safe handling, feeding, and understanding the cues of their infant? Certification as a lactation counselor or consultant enhances the ability of the practitioner to assess breastfeeding skills and counsel for improved success in lactation. A little more background on how this approach kind of started for me. I have been an infant for just about 16 years now, and my 10 years of that 16 were completely focused in our NICU. I, at the time, was just having my own children, and I was often faced with circumstances where I felt like as an infant feeding therapist, I very much knew the developmental stages. I had a very good handle on stress cues and readiness cues and the overall health of that baby and the things that would impair it. But when it came to bottle feeding skills, I could really make that baby feed. I think we've all had that some foundation, especially if we've been in practice for, we knew how to get our babies to eat. But what we've found, and maybe you can relate to this too, is the breastfeeding progression has been tremendous over the past couple of decades. And when I was approached by a mom who wanted to feed her baby at breast, I felt that I was highly relying on personal experiences. I was calling our lactation consultants and they would come as able, but I didn't like that aspect of my practice. I didn't like the fact that I was just using some intuition on my own rather than clinical evidence. And so in 2012 was when I became a lactation counselor, and I feel like it had a huge impact on the tolerance of the feedings for babies and my approach. And I encourage you all, kind of as you reflect on what we're talking about today, to think about how that aspect of your feeding approach could potentially be enhanced with further knowledge. I won't focus on that completely today, but I will let you know that this is a big piece of the interventions that we do in our practice, because all of our OT feeding therapists are also certified lactation counselors. Therapy goals in our NICU setting. This is a pretty common set of goals that you might be able to also understand. Our infants have a goal to tolerate full PO feedings, 2 out of 2 treatment sessions without signs or symptoms of stress. We have a parent goal to help them to have that increased understanding to demonstrate supportive feeding techniques. And the infants also have a goal to demonstrate sustained latch at breast. But we have understanding that oftentimes, unfortunately, with our very early babies, in the way that feeding progression goes, we don't always see those babies become successful with a full feeding with the breast experience. So oftentimes our goal will read to establish feeding for 10 minutes so that we can at least make sure that they have that foundational knowledge of the active suck, swallow, breathe patterns in the sustained latch at breast. The feeding goals for our term and late preterm infant aren't that different. However, we have much less time often to be able to work with these babies. We want these babies to do the same sorts of things. We want them to be able to tolerate feedings without signs or symptoms of stress, to be seen as medically stable. Parents need to demonstrate those feeding techniques and verbalize the understanding of the feeding progression. The infant also has the goal of demonstrating sustained latch at breast with feedings, if able, with active suck, swallow, breathe patterns. And then if that isn't working, a supplementation plan is put in place with the pediatrician's involvement. So one of the things in comparison can again kind of reflect on is a NICU admission means we have more time. That term and late preterm infant that is out on the floor can have a very short window of time to be able to learn these new experiences. The average length of stay for infants in the NICU. On this chart, you'll see a point of reflection, and I know there's great variance in different settings, and we're all looking at ways that we can shorten that average length of stay. But the difference that I like to highlight is what it looks like between 32 and 36 weeks gestation versus more than 37 weeks gestation. Those babies that are born under 37 weeks, and maybe it's just a week or two, once they go into the NICU, they spend on average around 2 weeks in the NICU setting. The average length of stay for the well baby, again, quite different. With a vaginal delivery without complications, it could be 48 hours. C-section delivery without complications, 3 to 4 days. As a mom who has had the luck of being able to deliver vaginally, I can reflect on that and know that it was a whirlwind time where you're trying to learn all sorts of different things. People are coming in to congratulate you, and the feeling of bonding is there, but also kind of collaborated with that feeling of great sense of being overwhelmed, and I have to keep this little squirt alive. How do I do that? How do I feed them? So when we're talking about the comparison of what babies can do, preemies versus full-term kiddos, with the preemie, they may have respiratory distress and other breathing complications. The full-term kiddo, their lungs are fully developed when they reach that 40 weeks gestation. At 35 weeks, a baby's brain still needs to grow 50%, versus the brain has much more definition, so it's higher functioning with that of a full-term baby. They may not have enough body fat when they're premature to regulate temperature until they're at least 34 weeks, but we all know that it's based upon birth weight. If they lack insulation, they're going to be working much harder to sustain temperature control. Most full-term kids have enough fat and energy to regulate body temperature and other vital functions. Premature babies have feeding problems because their ability to suck and swallow is not fully developed until at least 34 plus weeks. With a full-term kiddo, we assume that they have that ability to suck, swallow, to be able to lead to healthy, rapid weight gain. We also understand that's not always the case. I'd like to use this picture of comparison of infant brain growth to help in that aid understanding of why my baby, who potentially is 6 or even 7 pounds, born at 34 weeks, is so sleepy and not able to feed well and struggling with their basic need skills when we're trying to ask them to act like a baby who is otherwise 40 weeks. That percentage of brain growth, that 50% greater from 35 to 40 weeks, is significant, but the picture speaks 1,000 words. And when I have parents kind of with that difficult time of buy-in, I'll oftentimes reference this data so that they can help to understand where their baby is coming from. They are not lazy. So again, the well baby versus the NICU baby. We need to know that early feeding skills are not mastered simply because the baby has achieved full gestational age. The factors that we consider, again, with all learning, is what was the practice experience? How many times were they successful in their feedings for them to be able to learn from that? What's the infant state control? Are they a super fussy baby due to withdrawal symptoms? Are they super sleepy due to symptoms of being lethargic related to being jaundiced? And the parent knowledge of reading those infant behavior cues is imperative for them to be able to know how to respond appropriately. What we also consider is maternal anatomy, milk supply, and understanding of breastfeeding strategies. They have a prenatal class that focused on breastfeeding. Do they have anyone else in their lives that have breastfed before? Do they have access to a breast pump? Do they have, again, going back to that infant behavioral readiness cues and understanding what their babies should look like prior to feeding, during feeding, and after feeding? We must know that healthy babies are not dependent on size. And a small baby can do very well, and the large baby might be that one that's lethargic. So homeward bound, and what about that long goal? Breastfeeding in the premature infant. I had already begun to tell you that with my experience, I had the focus of the NICU setting for my first at least 10 to almost 13 years of my clinical setting and background. But over the last 4 years, I have developed an outpatient infant feeding setting so that when babies discharged from the NICU or hospital, they had means of follow-up with active therapy support. So feeding skills, feeding as a new skill for baby and mom. From that foundation of knowledge in prenatal classes to application, how do I know I am meeting my baby's nutritional needs? Occupational therapy and its impact on treating the infant with feeding difficulty, which is the diagnostic code that we use to submit for insurance reimbursement. Signs that we know babies may benefit from occupational therapy are their feedings take longer than 30 minutes. The caregiver needs to offer extensive chin or cheek support continuously during the feeding to achieve necessary volume. That baby is a sloppy feeder with high volumes of leakage, or even that wet sounding as they're swallowing their feedings. Baby has a difficulty with overall coordination of the feeding, whether that be at bottle or at breast. So how do we achieve the long-term goal? In this picture, I like the idea of looking at this kiddo and kind of lining them up and hoping that they're going to latch. But as we move forward, I'm going to talk to you a little bit more about how this slide works and aspects of it that actually don't quite work as we hope for a successful feeding latch. So moving forward with our outpatient infant feeding clinic, I'd like to talk to you a little bit about a little one, JR. JR was the first baby born to a beautiful mom at 34 weeks gestational age. She was small, for her gestational age, weighing in at 4 pounds, 7 ounces. She required a NICU admission for her early arrival and small gestational age and spent days with us with issues related to her prematurity. During that time, this mom, like most moms, just wanted her baby home. She was able to visit, but had an extensive drive to get from her home into the NICU setting. But she did what she was told, and she initiated pumping, and this baby was fed with exclusive breast milk. When I got to meet JR in our outpatient feeding evaluation, she was now 3 weeks of life. She had been home for a little over a week. Her gestational age was now 38 weeks, and she weighed in at 5 pounds, 1.1 ounces, up 10 ounces from her birth weight. So her mom felt she was just huge, but she was very small in terms of gestational age still. So the attributes for JR are like most babies who are born with that late prematurity. She had poor arousal for her feedings, yet she was making it. She was deemed medically stable, went home from the NICU, but she continued to have limited endurance to complete her feeds. She had sexual breathe coordination to get the job done, but there were times where her mom still needed to offer her pacing cues. The poor oral motor control was something that she could find when she was going into the early latch, whether it be bottle or breast. She initially had slow weight gain, but as you can tell, she was up 10 ounces from her birth weight at 3 weeks of life. So we were very excited about that. She was showing that medical stability of being able to take in enough orally in order to gain weight and grow. One of the biggest complaints, though, for this mother of JR was she was unable to sustain a latch at breast. So JR was only 38 weeks old, but this mother had been pumping religiously for the last 3 weeks of her life, and she was ready to have something come of that, or that she could take a break from all of the pumping. So the first intervention that we provide in our outpatient setting is, with a great subjective interview, we can have a better understanding of what it is that's going along with this baby's feeding practice. We have to be able to recognize the current feeding plan to be able to know how we can move forward in making the feeding plan more time manageable. So on this form is just a quick reference point of what we're looking at in terms of indicating successful feedings. It's always important to know what this baby's birth weight was, what day of life we're on, if it's in the earlier interventions of this baby's feeding plan, and where our current weight sits. So as a whole, we would love for our babies to return to birth weight by approximately 2 weeks of life. Then moving forward, we would love for them to continue to gain weight about 5 to 7 ounces per week. So those are the measurable goals that we kind of talk about with parents, because it aligns with what pediatricians are also expecting to be able to define a baby as thriving. So when we're looking at their current feeding plan, we get as a 24-hour picture, because no success or failure is determined with just one feeding. On this form, what we talk about is the start of the feeding. What time did this baby show arousal? Did they arouse, or was this baby woken up? It's been 3 hours since the last time they fed. Do they feed 8 times a day? Do they use every column in this form and feed 13 times a day? What we know from a healthy full-term baby who's working on early breastfeeding skills is they actually feed 10 to 14 times a day in order to establish strong milk supply for their mothers. If they don't feed that often, we would love to assume they're getting higher volumes with lower frequency. But the babies that are coming to see us are identified to have difficulty or concerns with that progression. So we know we would love these babies to feed no less than 8 times a day or every 3 hours. So tracking the start of the feeding time, who woke who, how long did this baby breastfeed? So this, again, is another kind of very subjective measure, because what I found is most moms are tracking how long were they at breast, not necessarily how long did they breastfeed. So quality of suck matters. Were they consistently sucking and swallowing? Were those sucks more intermittent? Does mom have to hand express while that baby is there? Was the effort of a nuzzling type of effort where they were present but not necessarily even sucking? Or was there no effort at all? So again, without good education, this recording can be a big varying difference of what exactly the breastfeeding looks like. Feeding is active suck swallow, not just being present at the breast. So moving on down that column, did this baby require a supplement? I don't consider a supplement to breastfeeding as a separate feeding. I think of it as all one continuous feeding thought. Was that supplement able to be mom's milk, or did that supplement need to come from formula? And how does that baby do with the bottle? We want to know how long the start to the end of the feeding took, because again, it's relevant to say, I'm asking a mom to pump, but yet she puts her baby to breast on each side for 30 minutes on each side. And then she decides, gosh, it's now time for a bottle. She gets out a bottle of formula and needs to give this baby an additional 2 ounces. And then I'm asking her to pump. It's likely not going to happen because she's already used all of her energy to feed this baby in a very long time frame. When we have a situation where we know that breastfeeding is inadequate, whether it be due to latch or active participation or even early arrival, but we have a baby who's able to supplement with their mother's milk, we have a higher confidence of being able to achieve a long-term goal of breastfeeding. However, it is astounding how many babies present in our infant feeding clinic with breast attempts, often without success, with high volume need of formula supplementation, without that mom verbalizing any understanding of the need to pump. Supply and demand is a theory that goes back to the very bones of what breastfeeding looks like. And if a baby is unable to sustain a latch at breast in order to transfer milk, to gain weight and grow, and we have to use artificial means of supplementation, whether that be syringe, nipple, bottle, or supplemental nursing system, we have to recognize that the baby did not get enough from that mother just based upon their own effort at latch. And if we need more milk, we have to find a means to tell that mother's body, make more milk. Supply and demand does not have a magic bullet to it. And I so often wish that I could help mothers through this process, especially with the understanding of the pumping need. But what I've also learned in our education is have to focus on the things that we can control, not the things that are beyond us, like that baby's early arrival or feeding difficulty. Oftentimes, it is a developmental issue based upon early arrival and the environmental factors that they're currently dealing with. And if I can encourage this mom to only spend time on the task that's achievable for her baby, we can then etch out time in her schedule to also enhance her milk supply, so that we essentially, in the long run, can make this baby an offer that they can't refuse, where the milk expresses so very easily that the baby can be present at breast, taste that breast milk, and know that this goal is achievable. So reading further down that column, knowing when the time of the feeding is ending, we are then recording how many minutes did that take. Wouldn't it be lovely if we could keep them to the 30 minutes? That's always a goal. But I'm not going to lie. I think there is a lot of situations where when breastfeeding is kind of fuzzy and we're going through the quality of suck during that breastfeeding to be anywhere from consistent to intermittent, what we have to recognize is the feedings often will go long, because just as soon as you're ready to take that baby off breast, they start to go back to their sweet little non-nutritive suckles, as if to say, I love you, don't give up on me. And before you know it, another 20 minutes have passed and the kiddo still hasn't gotten enough nutrition. So these are all things that we kind of educate with return demonstrations while in feeding clinic. The pumping, how long do you need to pump? There is a big window for normal with all things. And so we will establish a goal of anywhere from 10 to 20 minutes. It's better to pump for a short duration than to skip it altogether. And how much volume of milk is this mom making? One of the things that was essential for me in educating on that progression from bottle to breast is knowing how much is enough. So when we're talking to a mom of a NICU baby who's exclusively pumping for medical reasons. A goal volume for her to express milk is anywhere from 24 to 30 ounces. And that is across the board for one individual singleton baby. What we have to consider is our babies that are born at 3 pounds oftentimes only need 1 ounce. And we can give false confidence to this new who's never had a baby before, who's only pumping, to say you only need 8 to 10 ounces a day because that's all your baby is taking. Potentially this mom starts pumping in a very kind of religious scheduled way based upon good education from the neonatologist and lactation consultants and nurses that are involved. But as time rolls on and now her baby is only taking 1.5 ounces per feeding, she's going to become tired and she's going to want to pump at a lower frequency. And all of those things are acceptable as long as we're kind of keeping this eye out on the margins of how much total yield does she have in a 24-hour day. Again, one of the frustrating things that we'll see in outpatient follow-up is the mom who was diligent in her pumping, but kind of lost track of what that long-term goal would look like and let the pumping go. Again, I'm not trying to sound like I'm a critic of this mom who's very stressed and needing some extra sleep because she doesn't rest while she's at the NICU. However, I think it's our job as practitioners to make sure that our moms are educated to know what components they must have in order to achieve a long-term goal that they have verbalized to us. It's not saying that they can't sleep through a pump session at night. By all means, when this mom is at her wit's end or highly stressed, we do see often moms sleeping through a session and dads taking those feedings if that baby's at home, or the nurses to say, leave them in the nursery. But what we have to understand when giving that advice is it's misplaced empathy. We could potentially be setting up this mom for further complications, whether that be reduced milk supply, impairing her ability over the next few weeks to achieve her long-term goal, or the potential of having her develop clogged milk ducts because her body is accustomed to being expressed every 2 to 3 hours. All of these things are things that we must keep track of as we're providing our intervention. So kind of to wrap up this form, we want to know what today's weight is and where are we at in terms of where this baby was at birth weight and we're sitting today. Are we behind? Are we ahead? What's the rate of this baby's growth? So knowledge is power. I'm going back to that realistic goals and developmental expectations for infants feeding. They're outlined for us, and this diary can serve as a tool to reflect on the positive behavior in feeding, work towards their goals, and have a plan during what is often a difficult, emotional, and sleep-deprived time. Supplementation goals. What is the volume that this baby needs to gain weight? We'd like to give them a checks and balances. So there is a blank in that previous screen that you saw where we keep logs. And how do we know what that volume needs to look like? For any of you that work with babies on the inpatient side in their first few days of life, you have a great understanding, hopefully, by working with your lactation consultants and nurses on the floor to say how many mils of breast milk or formula is considered a full feeding. We know that that target moves each day. We provide these feeding diaries with supplementation outlines based upon that baby's current day of life for our babies born at our hospital. And we educate them very early to know that what was okay yesterday might not be okay today. The 2 to 10 that they needed in their first day of life becomes 5 to 15 on the second day of life. And then on the third, 15 to 30. And then moving forward, every day, this baby needs to take a little bit more. We expect babies to diarrhea and lose water weight when they're first born. And the larger the baby, the more weight they tend to lose due to that water weight component. But we need to also recognize that we need to let parents know so they don't feel like they're never going to hit that target. By early education, we're allowing them to know what to do, understand why to do it, and when it's going to get better. Milk is not supposed to start at an ounce or 2 ounces or even 3. It's supposed to start as the colostrum stages with very small volumes, but 100% nutrition sound for what that baby needs in that time. The diuresing needs to end at some point and gains need to start happening. And if this baby is not coming to a NICU, they need to have close pediatrician follow-up to ensure that they are transitioning from weight loss to weight gain in a timely manner. So before we get into the postural and position modifications, a reference point that has come in handy for me as a practitioner who doesn't always carry a calculator, it is okay to have an idea of what that baby needs based upon their weight. So for instance, a 5-pound 0-ounce baby, based upon 8 feedings a day or feeding every 3 hours, needs 5 pounds 0 ounces, so 50 milliliters, based upon feeding every 3 hours or 8 times a day. Know that this is an average. Plus or minus 10 is always applicable when we're making assumptions on how much a baby needs. But a 9-pound 0-ounce baby needs 90 liters approximately every 3 hours or 8 feedings a day. Again, this education isn't for everybody. It can be overwhelming if you don't understand where I'm coming from. 7 pounds 0 ounces, 70, and so on. But it's based upon 8 feedings a day. It's one of those things that we've worked with our dietitians in our setting to help have a better understanding of when I tell you 30 is okay today, why is it not okay tomorrow? And we use that baby's birth weight and energy needs based upon calories to help these moms understand why they need to continue to pump, why it's important for them to feed their babies or pump every 3 hours in order to gain increased volume of breast milk. And this baby needs to continue to take more in order to transition from that weight loss to gain. So intervention number 2, postural and positional modifications to enhance the latch of your baby. We all know that baby who is fed with a bottle often is fed in a semi-erect sideline position. And I'll get into that a little bit more with our next intervention. But the same type of posturing is so important when we're trying to get a baby to latch at breast. That natural position for them is going to be in a semi-erect sideline position. We're combining our expertise of infant feeding development with oral motor control and infant state control with the lactation needs. So when your baby is crying at breast, what are they telling you? Are they telling you they're hungry? Are they telling you, I hate this? Are they telling you, I hate your breast, which so many women have this perception of? Or are they simply saying, I'm so frustrated. I don't know how to do this. Please help me. And these are the things that we can problem solve with our mothers. So improving the latch success and ensuring comfort. My go-to 2 positions for successful breastfeeding are the cross cradle and football holds to allow moms to support their baby and breast for optimal latch. So one hand on baby and one hand on breast. We have to recognize that this mom is not comfortable and lacking postural support. She is far more likely to have a painful and shallow latch with her baby. So going back to that foundation of knowledge that we have, we need to make sure that mom's shoulders and hips are in alignment. Her back is supported. We can use positioning pillows to conserve mom's energy in sustaining those appropriate positions. We can use a pillow support, but we can use a boppy or a breast friend pillow. And all of these variations of positioning pillows can come into play when we're trying to work on feeding multiples. So the cross cradle hold, the basic hold that we use with most of our babies in feeding clinic, where we can maximize on what mom's ability to control in their feeding. For mom, what that means is one arm has her forearm to the baby's spine. Mom's palm is to the baby's shoulders, supporting the neck, with her thumb and index fingers to her ears. The baby's chest is up against her chest. So notice in this picture, the baby's knees are not in her gut where she wants to be in that deep flexion from being in utero. Knees are kind of almost extended so that they're folding around the mom's chest. One of the biggest mistakes that I notice when moms are reporting a painful latch is that mom is not allowing this baby's head to lag back in order to open up a jaw angle. So the thumb and index finger to the ears feels very unnatural when moms are doing it for the first time. But if she would take her hand and push that baby's head forward, that kiddo has no room to nod backwards, open up that jaw, and come around the breast. So her hand that is not holding the baby is holding her breast in a C shape, wedging the breast tissue, using that hand where her thumb is on her breast in the same parallel alignment to that baby's upper lip line. For the baby, she is nose to nipple. She's got one hand up and one hand down as if hugging her mother's breast, and her knees are relaxed down from the abdomen. So the hand that is on mom's breast, I have mentioned enough to have milk is kind of a key piece to successful breastfeeding. But some moms can have great milk supply and not even know it. Maybe their pump isn't doing a good job, or maybe they're just engorged and the pump isn't working sufficiently because of the pressure gradients. Hand expression training is truly the #1 tool of education that I can give to new mothers in order to successfully achieve a breastfeeding goal. The interventions that we provide on oral motor feeding development will help a baby to achieve the latch. But when we can help moms to express her milk, we then can get to that statement of making an offer that he or she cannot refuse. To express milk, I'm going to place her fingers around the breast tissue with her thumb and her index finger 2 inches back from the areola. So again, in that C shape. As you bring your fingers together, you're going to bring your hand back and in towards the mother's chest. I have seen milk launch clear across the room, and it makes these moms and dads laugh so much, and it brings me a sick and twisted sense of humor too. But once they know that they can achieve this successful milk transition, that when their baby's latched and yelling at them and fussing and screaming and saying, I can't do it, they can use this hand expression to say, actually, you can, and I'm here to help you. I'm going to move this milk forward. So for the mom who has that painful nipple due to a previous injury and poor latch, or the mom who's tearful herself because her baby doesn't seem to love her breast or want to be in this breastfeeding hold, when we can show this mom that this essentially is not her fault, this is her baby's infant feeding development not being sound just yet, and that she can move this milk forward for her baby, provide that nutritional support, we therefore increase her confidence in wanting to practice this breastfeeding transition more. So our next intervention talks about our paced bottle feeding strategies. Again, oftentimes the bread and butter of what we do with our early feedings in the NICU setting. So I am a strong component of keeping that flow rate slow for our early babies, but even the full-term babies. I'll oftentimes use a preemie or newborn nipple flow rate to make sure that suck, swallow, breathe is optimal. This baby must be able to not gulp their feedings, but take it in this controlled way. So see in this picture how this little one is in a sideline position, very similar to that long-term feeding goal position of being at rest. I understand fully what we're doing when we're giving a baby a bottle and unable to breastfeed. We are honing in on the sensory motor component of the suck reflex. With bottle feeding, there's an easy button compared to breastfeeding. And at any given developmental stage, one can be easier than the other for varying reasons. When it comes to bottle feeding, the baby does not need to sustain a shape of a nipple like they do with breastfeeding and soft tissue. They can come on and off that nipple. Yes, they'll have leakage, but they don't have to organize nearly as much as what they do in order to sustain a latch at breast. It's just widely different. So when we're supporting that baby in the semi-erect sideline position, we know that we're neutralizing gravity and allowing the reduction of flow in the feeding. When the babies suck, they get a little bit of milk, but they don't get waterboarded from a gravity-dependent position in a high-flow nipple. very different from what we used to believe babies needed. It used to be common practice that a fast flow nipple would allow that baby to achieve nutrition without having to work so hard. And now, as technology, evidence-based practice has all evolved, and we're learning more and more about feeding success and what we determine success to be, we all have a grasped understanding that it's the quality of the feeding that's most important, not the quantity. So readiness cues are used before we offer a feeding. We do paced bottle feedings in order to complete the feeding with a slow, controlled rate. Babies should feed with a swallow at least every 3 to 5 seconds, but oftentimes a good goal would be a 1-to-1 ratio. We know there's high variance in what's happening when it comes to the feeding development, and our job as practitioners is to be able to read that baby, and I think we all do it well when we have baby experience. But what we have to, again, recognize is new parents do not have that eye. They're looking at their baby in a very cute type of way, but they don't know what eyebrows raised mean. They think that that cute little that is making when they're gulping, that we know as stridor, to be a sweet little squeak that they get to make. It's reason to potentially intervene and reduce flow, and they think their baby sounds like a cute little squeak toy, and there's nothing to change. What we again recognize is this bottle feeding can potentially be the easy button for milk transfer due to the easier latch ability of having a firm nipple. But it also can be very concerning for that first 30 seconds to a minute of the feeding, where babies are hardwired to suckle, to not start the feeding in a nutritional way of suck, swallow, breathe, but they are hardwired to latch to a breast, where they would have to suck at a high frequency of rates in order to achieve letdown in mom's milk supply. With bottle feeding, we bypass that. We again, if we didn't know better, would put them in a cradle hold position, put that bottle in their mouth, fill the nipple completely with that milk, and let them go to town. And what happens oftentimes is in the first 30 seconds of that feeding, that baby looks like they're a deer in headlights. They look very overwhelmed because they're not meant to start a feeding with a quick nutritive suck. They often need at least a few seconds to a minute of organizational time where they get to suckle, to in turn with breast achieve a letdown, where that transition then changes with a very interrupted rate a bit of that suck, swallow, breathe coordination. With breast, there's this burst pattern of feeding. Suck, swallow, breathe, suck, swallow, breathe, suck, swallow, breathe during letdown phase. And then that baby transitions back into a non-nutritive suckle, suckle, suckle before milk starts flowing again. Moms that have any kind of reference point with pumping can see that milk flow and how that transitions, even when they don't necessarily change the settings of their pump. But we have to have that understanding of what the baby is hardwired to do in order to provide proper interventions on the bottle component. In our setting, in the outpatient avenue, oftentimes when I see a baby who's coming in using syringes for their supplementation, I like the theory of a practitioner to say, gosh, if it's not broke, don't fix it. If this mom or dad, they're not reporting any kind of difficulties in their current feeding practices, I will provide a great interview to be able to say, gosh, are you sure they're not giving us stress cues? But if a baby is using a bottle maybe that I'm not so comfortable with, or using a flow rate that I kind of have concerns about, I am a see to believe therapist. I do think there's proof in understanding what it is that they're giving this subjective interview about. But I also love the idea of letting the parents make that final say on what bottle they feel best with. They oftentimes have spent a great deal of time scanning all of the different bottles that they desired for their baby showers, not knowing that they were going to have an early baby. So we know our best practice is to provide them with a very slow nipple. And at any moment that they're starting to identify that concern with me, to say, gosh, they gulp, or is this right that I have to change the spit cloth 3 times during the feeding? That's my open door to say, actually, these are the things that we do, and this is why. However, I recognize that every baby, every mom, every human being is different. And just because I have beliefs on current structure and what has been most successful for me in my interventions, it doesn't mean that some 35-week babies can breastfeed exclusively without supplementation, or some 38-week babies can tolerate a level 1 nipple and bypass the need of preemie or newborn. It is not my place to tell them that it's broken, but it is my place to educate on what the good quality signs of feeding will look like. So going back to the mom, we must address maternal comfort for the long-term goal of breastfeeding. One of the things that was really enlightening for me as a new mom and practitioner who was transitioning to become more of an expert in the breastfeeding skills, the average standard size of a breast pump flange actually only fits 45% of women. And here I thought as a new mom, it was just me. The pumping parts that are oftentimes given when moms are purchasing their new pumps are usually one size, and it's a one size assumed fit all. But in early education that I was able to achieve with the transition of breastfeeding, most women need to change the size of their flange 3 to 5 times within their first 14 days of lactation. We recognize that the breast changes. Women that can essentially have flat nipples within their whole history, all of a sudden are working to elongate their nipples through the act of pumping, wearing a shell within their bra so that their babies can achieve a better latch. That size of the areola and the way that their nipples elongate determines the need of the sizing on that flange. So the flange that's too large draws in too much of the breast tissue, and it's not something that you can assess within the first minute of pumping. You have to give that mom a little bit of time with the suction, turn to her perceived comfort level, and then see where that flange size is fitting. When it's too small, you'll see the areola, the darker pigmentation of their nipples, actually stretching, where you see white pigmentation starting to develop because of the skin integrity becoming compromised over time. This is something that if you do not feel comfortable with as a practitioner, reach out to your IBCLCs and your nursing staff who do have a comfort level. Because this mom, if she's not complaining, but yet you see blisters on her nipples, she's probably feeling that she shouldn't say anything because her baby's going through enough and she shouldn't complain. And so many women are like that they don't want to speak to their own needs. They're so busy worried about their babies. And it's very much, I think, overlooked within the NICUs and many settings where we're all so busy caring for the infant. And mom's no longer a patient, and she just shows up with her milk and we say, thank you, you're doing a great job. But we don't ask the open-ended questions of, how is it going? Is it hurting? Because if it's hurting, it shouldn't. And giving her the support of a lactation consultant that can help make it better. I think our role, at least for our setting where baby is our patient and we have orders for feeding difficulties for that baby, we can also become quite busy treating that baby that we don't recognize the needs of the mother. But as a dyad, in order to achieve long-term skills of breastfeeding, we have to recognize where she fits into this feeding plan. So going back to our sweet JR, our plan and anticipated results for her progression were to strengthen her infant feeding cues, to promote adequate feeding skills through supportive techniques. What we did was we strengthened her oral musculature through practice. We fostered this neurobehavioral development by feeding her with reduced stress. We knew the stress cues of JR, but mom's stress cues can also play a huge piece of the puzzle of not only how bottle feeding is going, but how breastfeeding is going. So educating mom on those readiness signs, knowing that stress can be avoided and how she can respond for optimal behavior. So babies who are born early, we all can recognize they often will lack hunger cues if we leave them to their own accord. And it's oftentimes encouraged with these early babies to ensure that they eat at least every 3 hours in order to gain weight and grow, so that we hit that minimum number of 8 feedings in a 24-hour period. So readiness scoring has gotten more light as some clinics have moved towards an infant-driven feeding model, but that readiness cueing can be when the baby wakes up on their own, but it also can come when we do a diaper change and we start talking to that baby and we give them a pacifier so that they can start to organize their suckles and then show readiness. However, as we transition these babies to a position at breast, if you do not have strong readiness scoring, and that's a strong 1, or at least a strong 2 that's sustained when it comes to the readiness scoring of infant-driven feeding, we have to be able to say, gosh, they can sustain a level of alertness despite being so snuggled up with this wonderful mother. Moms and babies release endorphins when they're together, and it can be a beautiful thing for breastfeeding success, but it also can cause babies to become so cozy that they forget they were supposed to be hungry, and their need of sleep will start to trump that need of hunger. But when that mommy can recognize that it's not her baby just not wanting to breastfeed, or their baby being lazy and just wanting their bottle, but they see it as what it is, the release of endorphins, because they recognize it's their mom now that's holding them in this very warm and cozy position. They still need to eat, but they just can't fight that feeling of snuggle. So when that mom can recognize that, she's much more motivated to continue that bottle pumping of breast milk supplementation gain that is still needed for that baby in that time. The signs of the adequate latch and milk transfer of not just being present at breast, but to know when audible sucks, swallows are taking place, so that she doesn't need the scale that we're providing to her when she comes to see us in the feeding clinic, but she can know that a sustained active suck swallow pattern for potentially 15 minutes, maybe even just on one side, can be all that baby needs in order to gain weight and grow in milk transfer. Please know that that sign is very based upon mom's milk supply and rate of milk expression, as well as the baby's rate of milk transfer. You cannot put a time constraint on a breastfeeding interaction unless you know more. Some moms have a hyperactive letdown response where their babies can achieve a full feeding within 5 minutes, where others have worked very long and hard on achieving milk supply, and they do have adequate milk supply and fall into that category of 24 to 30 ounces per day. However, in interviews, these moms will often admit they have to pump for 20 to 30 minutes using a double electric pump with hand expression in order for the milk to just constantly trickle for that 20 or 30 minute duration. So we have to understand that potentially the workload of that baby in milk transfer is much higher than that of the mom with a hyperactive letdown response. So we're promoting those infant handling techniques, giving optimal posture for state control, and progressing these infants to exclusive breastfeeding if that's what these moms desire to meet nutritional needs for age-appropriate weight gain and growth. It's also important to recognize this did not happen in the case of JR. She did wonderfully, but there are plenty of women who start the progression towards breastfeeding and realize they like the control of pumping and knowing how much their baby gets. They like knowing that they can do that and still offer a bottle for adequate weight gain and growth. It is not my place as a practitioner to tell this mom what her feeding goals should be. My place is to provide intervention and education to achieve the long-term feeding goals that they establish with the idea of developmental milestones and how they can progress with that feeding goal. Our outcome was beautiful breastfeeding. It was cue-based feeding. She was able to breastfeed without supplementation. This baby continued to bottle feed 1 time a day without any stress cues, and additionally as needed for convenience. One piece of the bottle feeding component that we recognize as we discharge our babies who have reached that outpatient long-term feeding goal of exclusive breastfeeding is the bottle feeding skill doesn't just go away or sustain on its own. The bottle feeding is a practiced activity that all babies still need, despite having been successful with it before. I've seen very, very, very many women come to us later with a phone call or with their baby at 3+ months of life to say, would you believe it? My baby is now refusing a bottle. After all of that work that we had to use to transition them to breastfeeding, So my outcome measures and discharge recommendations are always to keep an eye on that bottle feeding skill. So whether that means once a day or every other day, no less than once a week, does this baby need to have the practice of the bottle feeding component if this mother wants to ensure that they can step away from a feeding and have a pump as an option. If this mom needs to go back to work, it's even more so imperative. But this little kiddo, JR, she was developmentally on target for her age-specific test. She was only 38 weeks when we met her in outpatient feeding clinic, but by 40 weeks gestational age, she was exclusively breastfeeding and all of these things that we said. We had baby gaining healthy weight. When we have a happy baby gaining weight appropriately, we have a happy mommy and vice versa. Our outpatient OT intervention allowed this little one to change the idea of what she needed to do for her breastfeeding from the call of duty for her sick baby, an idea that she needed to do this to one that she was actually quite enjoying. It was efficient. It was no longer a need. It was a desire because it was convenient and it established such great bonding with she and her baby. And this last little picture that I have here is of one of my 4 little ones feeding her sweet tea. And it's just so lovely to see when we can strengthen that bond with mom and baby, what that does for self-esteem and understanding readiness and stress cues. We have given them not only foundational knowledge of feeding skills, but that enhanced intuition of how they care for their babies, when things go awry and don't meet that level of predictability, when to call their pediatrician or practitioner, and knowing that they do have that ability to provide nourishment as needed. Thank you so much for all your time and attention. I'm now available for questions and answers.
I know that we've run over in time, but we are going to take just a few questions because we still have the majority of people are on. So, Elisa, are you ready for a couple? They're really quick questions. Are you ready for them?
I am. Can you hear me okay?
I can. We're good.
Okay,
great.
Great.
What can you repeat? Somebody just wanted you to repeat from that chart the daily recommended amount for a 5-pound infant.
Yeah. So what I was trying to say is there's a little bit of a trick that we can use based upon the 120 kilos per kilo per day for the babies that we have our dietitians tell us that our kiddos need oftentimes in the NICU. And the cheater way that I have come up with over the years is if you know your baby is 5 pounds, 0 ounces, what we can then determine on average is they then need 50 milliliters based upon 8 feedings a day or every 3 hours. And again, this isn't an exact, this follows that our wonderful dietitians have presented us with, but the idea is that a 7-pound, 0 ounce baby needs on average 70 milliliters every 3 hours, 8 times a day. 9 pounds, 0 ounces, 90. And so again, we give this as a way of educating parents on the checks and balances of what their kiddos should eat. Honestly, sometimes I'll hear pediatricians who are concerned on growth for a 7-pound kiddo then tell moms to feed their babies 3 to 4 ounces every 2 hours, and then they're coming to me like, won't do it. They must be ill, or they might not be able to take their feedings like they should, and it's not a realistic goal. And I use it as the same type of tool for the baby who was just born, who's 9 pounds at a full-term gestation, who isn't eating well. We initiate early supplementation because they won't latch. They're not going to do well with just a half ounce to an ounce a day. They're going to need that gradual increase before we'll be able to see them start to gain weight. And that's just an example of why we use that education.
Great, thank you. We'll just take one more. What is the difference? And this is a great question. I know many feeding therapists are trying to pursue different paths. So what is the difference between a lactation consultant and a lactation counselor?
Yeah, that's a great question. So an IBCLC, or International Board Certified Lactation Consultant, is someone who has gone through the extensive training and credentials with continuing ed, observation hours, to then sit for an international exam that then results in board certification. So by all means, it is the gold standard of being a lactation consultant, and then it also has a renewal process. As a lactation counselor, the certification is much less, but it's a great way to get some entry-level skills. The counselor certification oftentimes only requires a 1-week education course of 40 CEUs. And a lot of people actually use the lactation counselor certification to bridge themselves into an IBCLC certification. So if you're kind of just thinking about, gosh, where do I get started? I would highly recommend becoming a lactation counselor. And I've felt, over the years, more interest in pursuing myself to the IBCLC certification. Haven't made time for it, and that's on me. However, if it's something that you as a therapist desire, just to increase your knowledge, it's a great way to kind of get some entry-level knowledge that you can then build upon.
Great, thank you. All right, I know we're over time, so we're going to wrap up. As we wrap up this, so by the way, everyone, if you've entered any other questions that we didn't get to, or if you have any other questions and think of them in the next hour, if you email us them at medinfo@drbrownsmedical.com, we will have Elisa answer all the questions in addition to what she's already answered, and we will post them on our website along with the recording. So as we wrap up this presentation, Dr. Browns Medical would like to thank Elisa again, as well as all of our attendees. We have 2 upcoming fall webinars that we are very excited about. One will include a presentation on infant-driven feeding, which will include an overview of the program, along with therapists from 3 different hospitals speaking on their experiences with implementation of IDF. To end the year, Kelly and Jessic will be presenting on neonatal therapy and hypoxic ischemic encephalopathy. Dates will be announced soon, so keep on the lookout for those. Thanks, everyone. Have a great day.